imagine for a second that you have like this incredibly complex high-end stereo system.
Right.
You want the music to be just a little bit louder, maybe a little more vibrant. So you reach out and you just crank the volume dial all the way up.
Oh, yeah.
But instead of just getting the richer music you wanted, suddenly every single subtle background noise, every scratch on the record, the faint hum of the amplifier, it all just becomes overwhelmingly intense.
Yeah, the system didn't physically break, right? The hardware is actually perfectly intact.
Exactly.
But it's experiencing this sensory bottleneck where it simply cannot process that sudden massive influx of data all at once.
Exactly. And today, we are taking that exact concept, that idea of turning the sensory dial all the way up, and we're applying it to the human nervous system.
Which is fascinating.
It really is. We are doing a deep dive into a highly requested, very complex, and honestly kind of taboo topic for you today. We're looking at the world of female intimate rejuvenation.
Yes, we are.
And we are zeroing in on one very surprising, very specific focus question, which is, can a treatment designed to improve your sex life actually work too well and cause excessive sensitivity?
Right, which, I mean, that sounds like a marketing gimmick disguised as a warning,
Oh, totally.
But when we actually analyze the clinical data, it reveals these profound realities about how our nervous systems respond to rapid cellular regeneration.
Right. So to get to the bottom of this, we are looking at a huge stack of incredibly detailed sources.
Yes, lots to cover.
We've got clinical guidelines from the NHS in the UK. We've got extensive reports from the Royal Australian College of General Practitioners, that's the RACGP, and treatment protocols from various medical spas and women's health clinics.
And our mission here is really to strip away all that glossy marketing jargon. We need to look purely at the cellular biology behind what is commonly marketed as the O shot or the orgasm shot to determine if, too much of a good thing is actually a legitimate physiological side effect or if it's just clever advertising.
Okay, let's unpack this, because anytime you hear the word shot, the immediate assumption is that a doctor is injecting some highly engineered synthetic pharmaceutical into the body.
Right, like a drug.
Yeah, exactly. But with regenerative medicine, the mechanism here is entirely autologous.
Autologous meaning the material comes straight from the patient's own body.
Right.
The O shot utilizes platelet-rich plasma, or PRP. So the clinician draws a small vial of your blood, just similar to a routine lab test, right?
It's a standard blood draw.
Exactly. And then they place it into an FDA-approved centrifuge, and the specific gravity of the blood components allows that centrifuge to separate the red blood cells and isolate the plasma.
Which highly concentrates the platelets.
Exactly, yes.
Which I know clinics often refer to as liquid gold,
Yes.
right? Because of its yellowish appearance and just the sheer biological value of it.
Absolutely. Liquid gold is the perfect term.
And since this is your own tissue, you completely bypass the body's immune rejection system. It's your own biology.
Yes.
But, I mean, what are those concentrated platelets actually doing once they are isolated?
So platelets are basically the body's first responders. Whenever you sustain an injury, platelets rush to the site to form a clot, but more importantly, they release a payload of growth factors to initiate tissue repair.
Okay.
In the PRP serum, we are looking at massive concentrations of specific proteins. So you have VEGF, which is vascular endothelial growth factor.
Vascular endothelial, okay.
Right. And this acts as the biological architect for building entirely new blood vessels.
Wow.
Then you have PDGF, platelet-derived growth factor, which stimulates cellular division, and TGF-beta, transforming growth factor beta, which directs the structural remodeling of collagen and the tissue matrix.
Okay, so when this liquid gold is injected directly into the clitoris in the anterior vaginal wall, the area associated with the G-spot, you are essentially orchestrating a highly localized healing cascade, but without an actual injury.
Precisely. You're hacking the system.
I picture it like having a patch of grass that's thinning out. You could spray paint it green to make it look superficially healthy, sure.
Right.
But this PRP process, it's like intensely aerating the soil and delivering a hyper-concentrated custom fertilizer straight down to the root system.
That's a great analogy. You are fundamentally altering the biological infrastructure there.
Yeah.
The downstream effect of introducing that VEGF is a process called angiogenesis.
Angiogenesis.
Right. The endothelial cells lining your existing blood vessels, they begin to divide, they form new cellular tubes, and they basically weave together into a completely new, denser vascular network.
And more blood flow means more oxygen, more nutrients, and better nerve function.
Absolutely.
But what's really striking to me about the source material is this setting where this profound structural remodeling takes place. Like, you'd assume rebuilding vascular networks requires an operating room, right? And general anesthesia.
You would think so, but no. The clinical protocols show it's administered in a standard office setting, usually in under an hour.
And without general anesthesia, the clinics note they just use a highly potent topical numbing cream to manage the discomfort of the injection.
Yeah, the standard is often a compounded formula known in the medical field as a BLT cream.
BLT, like the sandwich.
Exactly like the sandwich, but it stands for benzocaine, lidocaine, and tetracaine.
Okay, got it.
And the combination of those three anesthetics blocks the voltage-gated sodium channels in the nerve endings. It temporarily stops pain signals from reaching the brain.
So the patient literally walks in, gets the numbing cream, receives an injection of their own concentrated growth factors, and walks out.
Yep. Walk in, walk out procedure.
But, okay, if this liquid gold is so potent at rapidly building new vascular infrastructure and forcing dormant nerves to regenerate, does that biological mechanism directly cause the hypersensitivity mentioned in the clinical FAQs? I mean, this is our core question today.
The neurology confirms that it absolutely does.
Wait, okay, I need to push back on this a bit based on the biology we just outlined. If the PRP is permanently, or at least semi-permanently rebuilding the nerve density in the blood vessels, why would the hypersensitivity only be temporary?
Oh, I see what you're asking.
Like, if you have twice as many healthy nerve endings now, shouldn't you just be permanently hypersensitive? Is excessive orgasms really a medical complaint, or is that just the sign of a wildly successful treatment?
Well, what's fascinating here is distinguishing between the acute inflammatory phase and the long-term neural adaptation.
Okay.
When the PRP is injected, it intentionally triggers an acute inflammatory response. The tissue swells and the platelets release massive amounts of cytokines and histamines.
Right, the healing cascade.
Exactly.
Yeah.
And at the exact same time, dormant nerve endings that may have, lost their myelin sheaths or blood supply due to aging or hormonal shifts, they are suddenly flooded with oxygen and stimuli.
So these nerves are basically waking up in the middle of a massive inflammatory storm.
Exactly. The brain suddenly receives this enormous influx of sensory data from a region that has basically had a muted baseline for years.
Wow.
The central nervous system interprets this sudden flood not just as heightened pleasure, but as sensory overload.
The stereo system from our analogy.
Yes. The patient might feel intense pressure, overstimulation, or a lingering hypersensitivity that borders on genuinely uncomfortable. It's the stereo volume being blasted before the amplifier has fully warmed up and adjusted.
Right. And how long does that bottleneck last before the body actually adjusts to the new normal?
The clinical guidelines map out a very specific curve for this. The hypersensitivity generally spikes in the first 72 hours, perfectly correlating with that peak acute inflammation we talked about.
That makes sense.
But then, over the next 3 to 4 weeks, the tissue begins the actual remodeling phase. The inflammation subsides, the new blood vessels stabilize, and crucially, the brain's sensory gating mechanisms adapt to the new, healthier baseline of nerve signals.
Oh, so the brain essentially recalibrates itself to handle the higher bandwidth of information.
That's a great way to put it. The sources indicate patients typically reach a balanced, optimal level of restored sensation around 3 to 4 months post-procedure.
Okay, so it takes a little while to peak.
Right. And the structural benefits of that angiogenesis can last anywhere from 1 to 2 years before natural aging processes necessitate another treatment.
I mean, experiencing a few days of temporary, intense hypersensitivity seems like an incredibly mild trade-off for years of restored function.
It really is.
Especially when you look at the historical context of what women have traditionally been offered for intimate wellness concerns. Like, if we look at the data from the RACGP, the Royal Australian College of General Practitioners, there is a jarring contrast between this regenerative approach and traditional structural surgery.
Oh, the shift in treatment paradigms is stark when you examine those surgical trends.
It really is.
Yeah.
The RACGP reported that between 2001 and 2013, Medicare claims for labiaplasty in Australia jumped by a staggering 140%.
It's a massive increase.
Why did we see such a massive spike in women seeking out female genital cosmetic surgery, or FGCS, involving actual scalpels?
Well, that 140% spike really reflects a complex intersection of aesthetic pressures and a historical lack of functional medical alternatives.
Right.
Many patients sought out labiaplasties, which, involve excising or physically trimming tissue or clitoral hood reductions, operating under the misconception that altering the visual appearance of the vulva would somehow resolve underlying functional issues or improve their sex lives.
But the RACGP highlights a vital, unignorable anatomical reality here. The labia minora and the clitoral complex are derived from the primordial phallus during embryonic development.
Yes, very important context.
This isn't just excess skin you can casually trim away like a bad haircut.
Not at all. The entire region is a highly intricate network of erectile tissue, vascular beds, and incredibly dense branches of the pudendal nerve.
Which means taking a scalpel to that area carries immense risk. The NHS and other clinical sources issue severe warnings about these irreversible surgical procedures. And the risks, they go far beyond heavy bleeding or standard surgical infections.
Yeah, the great paradox of seeking structural surgery to improve intimate sensation is the very high risk of permanent nerve damage.
Right.
When tissue is excised, nerve branches are inevitably severed. This can result in complete numbness or, disastrously, a condition called dyspareunia.
Dyspareunia being chronic, severe pain during intercourse.
Exactly. The severed nerve endings can actually form neuromas.
What are those?
They're disorganized tangles of nerve fibers that just misfire constantly, turning what should be a sensation of touch into a signal of sharp, unrelenting pain. You're attempting to improve a high-fidelity stereo system by randomly cutting the internal wiring.
Oh, wow. That terrifying risk profile is exactly why we're seeing regulatory bodies completely restructure how they classify these procedures, isn't it?
It is.
Like in the UK, they're developing a tier system to categorize interventions. The O-shot, because it relies on autologous PRP, is firmly placed in the amber tier.
Right. The amber tier classification denotes a medium-risk, non-surgical therapy. It acknowledges that, yes, while it is a medical procedure involving needles and blood processing, it does not involve general anesthesia, and most importantly, it does not involve the excision of any tissue.
So what does this all mean? It fundamentally bridges the gap between being told by your doctor to just go home and do Kegel exercises and being prepped for high-risk red-tier surgical procedures in an operating theater.
Exactly. The red tier is appropriately reserved for those irreversible interventions that permanently alter the anatomy. The regenerative approach of the amber tier focuses on optimizing the existing tissue rather than removing it entirely.
But just because the O-shot sits in the non-surgical amber tier doesn't mean it's foolproof.
Not at all.
If you want this treatment to actually work, if you want to avoid neutralizing the entire process, there are some strict, frankly biologically fascinating rules the patient has to follow.
Bridging that gap between surgery and doing nothing means taking a very active role in your body's healing cascade.
Right. Looking at the pre-procedure protocols from the clinics, there's a massive warning that jumped out at me. A patient absolutely cannot take any NSAIDs for a full 7 days before and 7 days after receiving the O-shot.
NSAIDs being non-steroidal anti-inflammatory drugs. We are talking about extremely common over-the-counter medications like ibuprofen, Advil, aspirin, and naproxen.
And this feels totally counterintuitive. You're going into a medical office to receive deep tissue injections in a highly sensitive area.
Of course.
Human instinct says, oh, I'll take an Advil an hour before my appointment to reduce the swelling and take the edge off the pain.
Yeah.
But if you do that, you sabotage the liquid gold. Why is that?
It comes down to the pharmacological mechanism of NSAIDs. Their primary function is to block the cyclooxygenase enzymes, commonly known as KOX1 and KOX2. And these enzymes are responsible for producing prostaglandins, which are the lipid compounds that actually promote inflammation.
Oh, but earlier we established that inflammation is the exact signal the platelets need to begin their work.
Exactly. The very process you are trying to halt with the Advil is the biological trigger for the entire treatment.
Wow.
Platelets require those prostaglandins to aggregate and activate.
Right.
If you block the cyclooxygenase enzymes, you chemically deactivate your own blood platelets.
You are turning off the biological signal before it even has a chance to send.
You essentially render the PRP totally inert. The platelets will not release the VEGF or the PDGF. Instead of a localized healing response, you are merely injecting inactive fluid into the tissue, entirely neutralizing the mechanism of action.
That is wild.
The body's natural inflammatory cascade just must be allowed to run its course unhindered for the new blood vessels to form.
That just proves how deeply biological this whole process is.
Yeah.
And the post-procedure rules are just as strict. There is a mandatory 24-hour no-sex rule immediately following the injections.
Yes.
And the sources clarify this isn't necessarily about avoiding pain, right?
Right. It is fundamentally about microscopic wound care. The needles used for the PRP injections, while they are very fine, they still pierce the epithelial barrier of the vaginal wall and the clitoris.
Creating tiny physical entry points deep into the highly vascular tissue we just discussed.
Exactly. Those micropunctures require at least 24 hours to physically seal back up.
Hmm.
Introducing friction, foreign bacteria, or altering the pH of the environment before that epithelial barrier is restored, well, it presents a significant risk for opportunistic infections.
It makes complete sense when you look at it through the lens of wound healing. Now, while we are clearing up clinical realities, I want to address a major point of confusion in the marketing landscape that I saw in the sources.
Okay, what's that?
You see the O shot advertised everywhere, but right next to it, clinics often market something called the G shot. Are these two terms just interchangeable marketing buzzwords for the same procedure?
Oh, no. They are entirely distinct procedures with fundamentally different mechanisms of action. And honestly, confusing the two misrepresents what regenerative medicine actually is.
Okay, let's draw that line clearly for you. We know the O shot is autologous and biological. It uses your blood to grow new vessels and nerves. What is the G shot?
The G shot is a mechanical synthetic intervention. It involves injecting a highly cross-linked hyaluronic acid dermal filler, the exact same synthetic material used in products like Restylane or Juvederm, to plump lips or cheeks.
Wait, really?
Yes, directly into the anterior vaginal wall.
So they are taking facial filler and placing it near the G-spot.
Exactly. Its sole purpose is to temporarily increase tissue volume. The goal is just to create a physical protrusion that increases mechanical friction during intercourse.
The analogy that comes to mind is comparing a car's performance. The G-shot is like putting a lift kit on a truck.
Right.
It physically changes the dimensions and how the truck interacts with the road, but it doesn't change how the truck runs.
Right.
But the O-shot is like pulling the truck into the garage and completely rebuilding the engine to restore its actual horsepower.
That's a perfect comparison. The filler does not induce angiogenesis. It does not regenerate dormant nerve endings. It provides zero structural healing to the tissue matrix.
It's just a spacer.
It merely occupies physical space until the body eventually metabolizes the hyaluronic acid, usually over the course of a few months.
The mechanical versus biological distinction is so crucial, especially when we look at the actual medical conditions the O-shot is being utilized for, well beyond just sexual wellness.
Yes, exactly.
The clinical literature shows it being used as an adjunct therapy for some really severe pathologies.
It has shown significant efficacy in treating mild to moderate stress urinary incontinence by physically strengthening the tissue supporting the urethra, but its application in dermatology is perhaps even more striking, specifically for a condition called lichen sclerosus.
Which the sources describe as a chronic, intensely painful autoimmune condition.
Right. Lichen sclerosus causes severe inflammation, thinning, and tearing of the vulvar skin. Left untreated, it leads to intense pain, scarring, and the actual architectural loss of the vulvar structures.
That sounds awful.
It is. But the regenerative properties of PRP, specifically the tissue remodeling guided by that TGF-beta we mentioned, have been shown to improve skin texture, reduce tearing, and manage the chronic inflammation associated with the disease.
Wow. But the sources are also very careful to set boundaries on what the O-shot can achieve. It's an incredible biological tool, but it's not a universal cure-all.
Definitely not. It cannot override systemic hormonal realities.
Right.
If a patient is experiencing profound vaginal atrophy and sensory loss due to the systemic drop in estrogen that occurs during menopause, localized PRP injections cannot replace that missing hormone.
Rebuilding the engine doesn't help if there is no gas in the tank.
Precisely. The regenerative capacity of the tissue relies heavily on the presence of estrogen to maintain its thickness and elasticity over time. Therefore, the O-shot is best utilized not in isolation, but as one component of a holistic clinical care plan, often working in tandem with systemic or localized hormone replacement therapy.
Okay, let's pull all of these threads together. Over the course of this deep dive, we've stripped away the spa marketing to reveal the true cellular reality of the O-shot.
We covered a lot of ground.
We did. It is a non-surgical autologous treatment that isolates the liquid gold of your own blood, the platelet-rich plasma. It utilizes growth factors like VEGF to trigger angiogenesis, building new blood vessels, and forcing dormant nerves to regenerate, all without the permanent risks of structural surgery.
And we directly answered the central focus question that rapid influx of blood flow and nerve signaling can absolutely cause a temporary bottleneck in the central nervous system, resulting in excessive sensitivity or overstimulation.
Right.
But as the tissue remodels, the nervous system adapts, leading to long-term restored function.
It's a profound reminder that biological healing is an active, sometimes really intense process, requiring strict adherence to protocols, like avoiding NSAIDs, just to let your body's inflammation do its job.
And from a regulatory standpoint, the placement of PRP in the amber tier reinforces a critical patient warning. Just because a procedure doesn't involve a scalpel or general anesthesia does not mean it is without risk.
Absolutely.
Deep tissue injections and blood processing require strict medical oversight. Always seek out certified, regulated healthcare professionals because non-surgical should never be conflated with low standard.
Yeah, you definitely don't want someone unqualified handling your cellular material. As we wrap up this exploration of regenerative medicine, there is one final lingering thought from the research that I want to leave you with.
Okay.
Today, we've extensively discussed how science allows us to safely isolate our own blood plasma, re-inject it, and literally force the regrowth of nerve endings and vascular networks in our most highly innervated tissues.
The ability to intentionally trigger and direct the body's latent healing cascade is really one of the most exciting frontiers in medicine today.
It is. So if we can successfully harness this autologous technology right now to reverse tissue aging and restore nerve function for intimate wellness, how far away are we from a future where this exact same biological mechanism is refined to repair severed spinal cord injuries?
Wow.
Or to reverse the degenerative effects of brain aging? Or to completely rewrite the timeline of human cellular decay across the entire body?
It really forces us to question what other dormant aging systems in the human body are simply waiting for the right concentrated signal to wake back up.
Exactly. Because once we fully master how to safely turn up that volume dial on our own biology, there's really no telling what the human body is capable of repairing. Thanks for taking this deep dive with us. We will see you next time.